validity. So I want to start off with a little thing that's a sheep scale. So what I invite you to do is go to menti.com. I will put the link here in the chat as well. Or you can use your phone and just scan the QR code and just look at this sheep scale and how do you feel today, this afternoon? Which of those sheep kind of represents how you're feeling this afternoon, how you're showing up. And yeah, hopefully you can make that work on Menti. If not, you can also just put it in the chat, but we'll be using Menti again later. So if you are able to use it, then that's grand. And you can basically just sort of leave it open for later. And then we'll see how people are. There is no right or wrong. There's no expectation that you should all be sheep number 9 or that none of you should be sheep number 4 or whatever. However you're showing up is okay. I can see a few of you have already joined and added yours. So we have a few that are number 8, number 9, number 5, 6, 7. So quite a few different sheep. And why is this important? Because authenticity is really critical to all of this that we'll be talking about. How we show up really matters. But we don't need to be judgmental about how we show up. Just feel how you can show up and decide what each of us has capacity for in the here and now, and what we might need to be okay just now. What might help you if you were sheep number 4? Might be somebody just coming over and helping you lift that bucket off your head, kind of thing. So we all need each other. And there isn't one way of being. There isn't just one sheep that we should all aspire to be. And ultimately, it's about the diversity between us and supporting each other to be at our best. So that's one of the reasons why we love the little sheep scale, just as a little check-in to see how everybody is. And yeah, what we have capacity for, what energy we bring. So I want to start off with an example of human learning systems in practice. And this comes from Gateshead in the northeast of England. And it's about Juliet, who is a single mom working 2 jobs to make ends meet for her and her son. In the evening, her mother looks after Juliet's son so that she can go to work for, her second job. The next door neighbor in her council flat has recently started to become quite abusive and threatening. And so Juliet's mom felt no longer able to come over in the evenings, and Juliet had to give up that second job. So as a result, she fell behind on paying her bills, her mental health deteriorated, as did her son's behavior at school in particular. And before too long, they were heading for crisis and got a letter from the local authority that she'd fallen behind on her council tax bill. Of course, Juliet wasn't really in a position to pay it. Under normal circumstances, the next letter from the council would have threatened a visit from the bailiff, followed by further threats, and ultimately the dreaded visit by the bailiff. However, at that time, Juliet's local authority decided to try out something new, because they had realized that the assumption that most people who fall behind on paying their council tax only do so because they can't be bothered to pay it was actually wrong. In fact, when they looked at the numbers, only 6% of people who received the letters threatening with the bailiff were able to pay. The rest, the other 94%, weren't in a position to pay. And sending over the bailiff usually resulted in making a bad situation much worse for everyone involved. Citizens' struggles were exacerbated, and the local authority had to spend lots of money on bailiffs, unable to recoup any of the outstanding debt. So Gates had wondered whether it might be better to see the fact that someone had fallen behind on paying their council tax bill as a signal that they might be struggling, and to offer support rather than to add to people's woes. So when Juliet fell behind on her bill, the visitor at her doorstep wasn't the bailiff, but a caseworker who was curious to find out about her situation and see whether she and her son needed any support. When it became clear that her housing situation was causing a lot of the challenges. Her son regularly missed school or was late because the school was so far away from Juliet's council flat, and her neighbors' intimidating behavior was still having an impact. When the caseworker learned about that, they decided to bypass the existing system within the local authority and find Juliet another council flat that was much nearer to her son's school. Now, under normal circumstances, that wouldn't have been an option, as it went against the council's housing policy, stating that transfers couldn't be considered for tenants in debt. But suspending the workings of the system helped the caseworker to actually help and to do so quickly without too much effort. All it took was a couple of hours, some money for her son's new school uniforms, and before long, Juliet was able to get back, to go back to her evening job and was receiving the in-work benefits she was actually entitled to, but hadn't known about as well. So actually, it really helped her avert the kind of financial crisis. So what does this example show? I think first and perhaps most significantly, it shows that the systems we've designed are often based on really wrong assumptions. They try and force people like Juliet to be compliant, and they penalize her for not working enough hours, for falling behind on her bill, for not caring enough about her son to ensure he's wearing a clean school uniform and is at school on time. And as a result of all of these negative assumptions, they waste a lot of scarce resource on not actually helping people. Because too often we have processes focused on assessment, on eligibility criteria and thresholds that are withholding, to the greatest extent possible, any support that could make a positive difference. And secondly, the way forward lies in relationships. In that caseworker building a relationship with Juliet and trying to understand her, understand what matters to her and her son, and understand that actually she's trying her very best in a challenging situation. Understanding rather than assessing is really crucial here, because understanding is about engaging to learn and recognizing that people aren't the problem, they're part of the solution. What we need is recognition that the world is messy and complex, like in this picture. So we need to suspend our certainty and engage with people's real lives. Too often we're trapped in this narrative suggesting that solutions are simple and linear, just like those people in the box, that if we have great metrics and rigorous management structures and promote competition between different services, then everything will be fine, at least in our little box. But what happens when we actually open the door and see the reality with all its glorious messiness? Well, an increasing number of leaders and practitioners and academics are recognizing that just closing that door again doesn't make things better, right? They've embraced the fact that the world is messy and complex, and that the best chance we have to genuinely help people flourish is by centering public service around three aspects: placing humans and relationships at the heart of support so that we can move from transactional to relational public services. Secondly, bringing people together to learn with and from each other so that we can better understand what a complex issue looks and feels like from different perspectives. And thirdly, creating more connected systems that fit around people rather than expect people to fit into them. And this is what's been articulated as human learning systems, developed from really inspiring, really radically pragmatic work of people like those in Gateshead, of people like Gary Wallace, who's here with us, and his colleagues in Plymouth, and many others across the UK and indeed across the globe. And if you go on to the HLS website, which we'll send you a link to after the webinar, you can find more than 70 examples of HLS practice from various different fields. They show that everyone actually really benefits when we find an approach that's much more humanizing and that's able to support human freedom and flourishing. So I want to take you through those three categories: the human, the learning, and the systems, to just give you a bit more detail. And if you at any point have any questions, please feel free to either pop them in the chat or just raise your hand virtually and just come in. So the human bit around HLS is really recognizing that people have inherent potential that we can draw on, and that we need to support their agency through bespoke support rather than just expecting people to fit into boxes. We need to create the conditions for people to flourish, recognizing that it's both about the individual's uniqueness, but also that flourishing is an interdependent process. We need other people around us in order to flourish. To do so, we need to make sure that we actually give power to people who are in those relationships, that decisions can be made by the people that are most affected by them, together with them. And so co-production and relational decision-making are really critical for that. And we need to recognize that we have collective responsibility to humanize practice and to focus on relationships. So placing that humanity at the center of our work is really, really critical, rather than reducing people to numbers or statistics on a spreadsheet. So what that might look like is about recognizing the diverse experiences that people bring, and that we all add a unique perspective to a challenge. And the more we get into dialogue, the better we can understand the complex nature of an issue from different people's perspectives. So whether you're an expert by experience, or whether you're an expert because of your leadership position, or you're an expert because you're a practitioner working directly with citizens, all of this is really important. Now, with regards to learning, then, there are a couple of things that really perhaps shift the understanding of learning within human learning systems. So the first is that learning is liberating. Okay, so we want people to feel that sense of liberty when they're learning, to freed, to feel able to kind of exercise their agency. And therefore, it mustn't be a luxury. Learning is really essential, because in complex situations, when we recognize that the world is messy, is complex, that we're dealing with really complex issues, we can only gain insights and knowledge by learning together, by bringing those different perspectives together. And so we need to focus on that kind of emergent learning, on kind of creating an environment where we can keep learning as we go along, to see, is this a direction that we're going in that brings us further towards where we all want to be, or might we need to change something? So we need to be intentional, and we need to keep experimenting, keep testing things out, keep taking the next step forward, and reflect on that in order to understand what's happening. And importantly, we need to connect those learning cycles up. I'll talk a little bit about that in just a moment. So the aim isn't really to replicate what we've done before, to just copy and paste everything, but it's actually to increase our creative possibilities, to feel like I'm gaining more and more strategies as we go along, and I'm therefore better able to respond to whatever the situation might require. And so in this understanding of learning, it really requires a culture where people feel that sense of psychological safety, where people feel like they can make mistakes and see that as learning opportunities, rather than feel like if they make a mistake, then they're going to get shot down. So in human learning systems, we talk a lot about this learning cycle that is ultimately about bringing people together to understand the system, bringing different professionals, people with lived and living experience together to really understand what is the system and how does it look like, feel like from each other's perspectives, and how can we actually develop trust and a shared understanding of what our purpose is through these relationships, to then kind of go into actually what might be ways in which we can improve things. So to experiment, to design experiments and explorations, and then to test and learn, so that we keep learning as we go along. Gary is going to talk to you a lot more about some of these aspects in practice. So I'm not going to indulge too much into that. But critically, the other point is that then needs to be further embedded and needs to influence other parts of the system. So it's about how can we actually scale it up so that we learn from the ground up, rather than just being told top down what to do. So it's about how we can invert that and connect different learning cycles up at different levels. If we want to fully understand anything we're dealing with in our professional work, whether that might be well-being or substance use or homelessness or employability or whatever, it's not helpful to take that thing out of its context and break it down into component parts, but much more helpful to try and understand the web of relationships and interactions within which that issue exists. So that web is what we call a system, and we can apply systems thinking at different scales. So we can see it at the micro level. We can see a person's life as a system. We can look at their kind of relationships as a system, as a universe. And we can do so all the way through seeing our organization, our team, our service as a system, seeing our place as a system where there's different community groups, different individuals in the community, different agencies, and so on and so forth. And we can see our region, be that the southeast of Ireland or the entire country, as a system at a kind of macro level. And each of these consists of a variety of different people that make up that system and different factors that impact on that system. So it's all about those actors and factors. And in systems, outcomes are not the result of one single thing, one single intervention, but outcomes are the emergent properties of the interplay between those different actors and factors. Okay, so if you think intuitively of the ecosystem in which different species, so the actors and environmental conditions, like the climate or the terrain, those kinds of factors interact with each other in ways that are ever evolving. Because systems are really dynamic as its actors and factors keep changing. So what's critical to understand is that the health of any system matters a lot. Healthy systems produce good outcomes. Okay, they enable the actors to flourish. And so again, you can see that in any ecosystem, in your garden or in the sea, in the forest, where the system is healthy, life flourishes, species thrive. And the same applies in our individual lives as well. Any outcome that we care about is going to be much better if the system that affects that outcome is healthy. Yeah. So therefore, our job needs to be about the quality of relationships between the relevant actors and the trust between them. And so we need to focus on creating more relational systems, on being able, a bit like fungi, to influence, to infuse the entire system with that relationality. This idea of being like the fungi with this kind of invisible net across comes from work by Healthcare Improvement Scotland on HLS, and they just use that metaphor as a way to kind of illustrate that it's about being part of that system, and very often in very, very small ways that might be really subtle, but are still very, very important. So when we talk about that, then a system might look something like this, in terms of you can see the different actors and you can see the different factors that might sort of interact to create the outcome of well-being or not create the outcome of well-being if those interactions are not positive. And so that speaks to the fact that we deal with complexity. Another way to show that is when you look at the systems map for the outcome of obesity. So this comes from the Department for Foresight in the British government. And they tried to kind of map all the different factors that affect the outcome of obesity. And when you look at that, you can see that it's not very simple, right? It's incredibly complex. It's not that we do one and then, we do one thing and then somebody is no longer obese. But actually, when you break it down or when you group it, you can see that the media, social influences, psychological factors, economic factors, food production, activity, infrastructure, developmental factors, biological, like genetic factors, medical influences, all interact together to create that outcome or not. And that is just mentioning the factors rather than also including the actors, the people in somebody's life, who might be their role model, who might be close relationships, and how might they influence somebody. Okay, so hopefully that gives you just an idea of just how complex something is that might be perceived as very simple, or where we try to find simple solutions of like, we just put somebody on a healthy diet, or we just have this new injection that is going to solve all of this. Maybe it camouflages some of it, but these factors are still there, right? And so that's why we need to kind of take a fundamentally different approach, I think, to how we're trying to affect outcomes, and to be much more focused on doing things collectively across a system that actually works together, or at least brings together as many of the actors as possible. And so I will, at this point, maybe just take a break and give you a chance to kind of absorb some of this and have a little conversation in a breakout room to think about what thoughts, emotions, and practical ideas does any of this spark in you. Okay, so thinking of head, heart, hands, what might be some of the thoughts that you have on everything that I've mentioned there? What might be some of the emotions that brings up? What might be some of the practical ideas that may spark in you? And do we want to just check if people have any questions or any comments? Anything from your conversation that you want to share?
It's Suzanne here. I work with Roma, and just what you said really resonated. Like the whole basis of like sometimes people call Roma and travellers, like Irish travellers, and the ethnic minority groups, they call them hard to reach. But sometimes Roma can be hard to find. But if they're treated with respect and dignity, and if the relationship is fair and just and all the rest of it, there is absolutely no problem with Roma engaging. So just what you said about the relationships and trust, and that whole context is it's the difference between Roma working or not working. So that really makes sense. And even from my knowledge of intercultural work, it is all about the relationship, even just at that micro level, just at that very basic level. It's the starting point. Yeah, so thank you.
Yeah, absolutely. And I think that it's really important to keep in mind, like some of the work around HLS will require a fair bit of systems change, but I think the relational bit is something that is just about how do I show up and where do I put the emphasis? And, I had a social worker on a course last week who was saying like, she was dealing with a case of a mom who was in a family residential home with her newborn baby, and who had left the residential home without giving anybody any notice. And like her initial impulse was to phone up the mom and, tell her that that was really not okay. And there were all these concerns about baby. And then she decided, like, actually, let's put the relationship first. And she still had the phone conversation, but she started it with like, how are you? What's going on for you? It doesn't need dramatically more time necessarily or anything. Just that mindfulness of like, let's just treat you as a human being, and let's try and understand like what's going on for you, what matters to you, what's important to you. And then we can have the same conversation, probably much more productively, because we've started off with me recognizing you as a human being and vice versa. So it's sometimes as simple as just doing something that is more relational to start us off. So it all comes back to like, how do I show up? How do I show that I'm curious about you as a human being? Any other thoughts or questions?
Yeah, just I'm also an expert by experience with mental health as well. So yeah, all very interesting. I love these sessions and stuff. Your last slide, I really connected with it, because obesity, for me, that's, I suppose, that's where I'm doing a lot of work myself on, as my illness, obesity, and all what you had on the slide and all the rest. It was just so connectable to me and the whole lot. And then when you mentioned about the injection and stuff like that, because I get totally all that. So then when we were having in the breakout room and all the rest, it's just kind of in a roundabout way, no matter what, in systems, education, and the whole lot, it's the links of people all together and the communication between everybody else. So one of the things that kind of said is, there's all these different jigsaw pieces, but you can't put it together. You can put some of it together, but you can't put it all together. And that's what we need to, I suppose, work on and change and do whatever. So thanks for that.
Well, can I jump in and say something really briefly? It's just building on what that lady said and what Gabrielle said. We're starting to work on diabetes within the Roma community, and I found this really good publication. It's from the UK, and it was around language matters, and it was a guidance for healthcare professionals not to locate the blame for diabetes with the patient. You know, so the question, just simple ways of rephrasing, but it's just what Gabrielle was saying, like the non-judgmental approach. So instead of like, well, that wouldn't be very good for your diabetes, you know, eating chocolate or whatever. Just you know, question like how are you managing? But just that idea of language and the whole not judgmental thing. And it just reminds me, like, so we have in Ireland, we have All Ireland Standards for Community Work Practice, which is very much based on community development principles, but they're completely aligned to what Gabriel has just articulated, you know, in terms of those values and principles. And that community development work approach really is really, it works really well for us with our excluded groups in the Southeast. So it's just to say that.
Thanks for that. Yeah.
Awesome. So will we hand over to Gary to freshen this up with a few more practice insights?
Jim asked me to talk about a particular human learning systems forum, which is called the Creative Solutions Forum, which so I work for this thing in the bottom corner there, the National Institute of Health Research, Health Determinants Research Collaboration, Plymouth. So I lead a team of 6 embedded researchers that are embedded in the council and the city. I'm kind of half and half the university and council, and I'm a public health person by background. So
Gary, you might need to just redo the screen share, because it's sharing your presentation as a like working document as opposed to.
All right, okay, let's try again.
The slide.
Whoop. What can you see?
Nothing at the moment.
Okay, right. Okay. I don't know why.
Yeah, so if you go onto your presentation, Gary, and just click to make it bigger, we're seeing it as a.
Yeah, so I'm seeing it as a proper presentation.
Yeah, if you go back into Zoom and click share, it should give you, amongst all the different windows, it should give you both the option to share the PowerPoint slideshow as opposed to the file.
Share screen.
That makes sense.
Windows.
And you need to have started your PowerPoint.
Oh, you need to have started it. Oh, okay.
Yeah.
See, I'm sorry, I'm a complete Zoom virgin. I don't know how you do it.
I thought it was the
Now I can't see. The thing is, when I go into full screen, I can't see Zoom. Hold on. No, let's see Zoom. So yeah, so I can't start my present. If I start my presentation, I can't see Zoom.
It's okay, Gary. If you want to put it on, and we can just increase the thing on the screen. It'll be okay. Yeah.
So if I kind of blow it up a bit, is that any good?
Yeah.
Yeah.
So yeah. So the background to this is, as I was saying in the breakout room, we have an alliance contract, which is a legal partnership between the council and the NHS and 7 drug and alcohol, housing and homeless services, and they subcontract to 18 other services. It's a 10-year contract. We're currently refreshing all the original work we did, but the way the alliance works is we give them all the money that we used to have, and that alliance is free to choose what it does with that money in the field of complex needs. And in England, we use the Making Every Adult Matter definition of complex needs, which is substance misuse, mental health, offending, and housing and homelessness. So let me just, there we go. So an alliance contract is a different kind of contract. So it's a vehicle to share risks. It's a way of working based on alignment and commitment. It's a bit like the EU, actually. All of the members of the alliance retain their individuality. They just pool a little bit of sovereignty. And if I show you, kind of a traditional contract is kind of like this on the left. You'll have a commissioner and they'll commission all these different services, and they commission them independently, and none of them talk to each other. They're all kind of separate entities. But in an alliance, the commissioner becomes part of the alliance. And then you have, in our case, the director of commissioning acts as what's called the owning commissioner. And their role is to problem solve, not to performance manage. And the other thing is the alliance is a values and principle-based contract. And these are some of the alliance principles. As you can see, it's all about collective responsibility, decisions made for best for people using services, not what's best for services. Now, as part of this process, we set up this thing, smaller, called the Creative Solutions Forum. It's been running for 9 years, and it's part of a learning loop. So in human learning systems, the strategy is learning. And so we had if you think about, so we had all the chief execs and all the commissioners in a group called the optimization group. And then we had this forum, which was a practice forum, a forum of last resort for the most serious cases in the city. They had to have been failed by all other business as usual practices before they could come to this. And what we would do is look at the cases. And as you will know from your own work, if the system were different, a lot of these cases would not be intractable. And we would feed that learning back up to the optimization group so they could change the system. So this is why we set it up. So we had loads of learning from what are called serious case reviews or serious safeguarding adult reviews. When a vulnerable person dies, you get in a reviewer and they review the death and they make recommendations. And we were sick of, you could virtually predict what the recommendations would be because they were always the same, and there never seemed to be any change. It was about people falling between the gaps in services or being denied services and ending up dead, really. And we thought we really should try and stop that happening. We'd had a lot of learning from the co-production work we did with putting the alliance together. And all the kind of problems we'd found is how everyone works in their silos, the thresholds are impossible for people to meet, that nothing was done in a bespoke way. Everyone was getting the same package of 6 things or 4 things. And everyone felt, everybody, staff, commissioners, that the system wasn't working for any of them, let alone for the people using the service. And we learned from research as well. So the research evidence, I've just really kind of very quickly go through this. So the model we all work in, you two, is called New Public Management. And it comes from a thing called public choice theory, 1962, by a famous liberal right-wing neoliberal economist called James Buchanan. And it focuses on three things: markets, because there's an idea that competition is a good thing, metrics or quantitative proxy targets, so KPIs, which often bear no relation to anybody's lived experience. And if you're going to do markets, you're going to do metrics, you need a whole class of workers to manage those, and that's where the managers come in. We now have over 30 years of research from all over the world that says it doesn't work in complex human systems, because it makes these linear assumptions, really simplistic cause and effect chains about why people are in the circumstances they are. But what we know from research is that actually human systems are called complex adaptive systems, and they are non-linear. So it's not A doesn't cause B, that you can't control these systems, they're uncontrollable. And that any good things that happen because of the whole system. Just as that foresight obesity map shows you all the really kind of complex interactions that cause the emergence of obesity, all those complex interactions, if you get the system right, cause the emergence of good things too. This is one paper. This is a systematic review. This is the highest order of evidence. It studied all the studies of new public management around the world over the last 30 years. And 80% of those studies find people gaming targets. And 74% of studies find everyone lying to everybody else about what's actually happening. And human learning systems is about not doing that. As I've said, this is because they assume things work like a machine, systems work like a machine, and they don't. These are the features of a complex adaptive system. A kind of plain English version of that. You are going to get these slides, so don't worry if you're not. I'm going quickly. I'm trying to get to the interesting things. The plain English summary, you can tell if a system is complex or open when it's got many elements. Basically, that's human beings interacting dynamically and in ways you can't predict. You can't, by studying those people, you can't tell what the whole system is doing if you study them in isolation from the system. That the system is constantly interacting with this environment. So in our group, we were talking about the way you could have a brilliant project and then there's a change in benefit systems or the law, or there's a pandemic, or there's something else happening. Everything kind of overnight changes. The whole system repatterns. So the problem we've all had in the developed world over the last 30 or 40 years is the world of health social care is complex and adaptive, and the way we've been commissioning and delivering services hasn't accounted for this, and it's tended to make things focus on the wrong things. A lot of our practice has become packaged and not flexible, doesn't recognize, can't react to the infinite variety of human beings. We focus on targets, and all those targets are about fixing broken people rather than trying to understand the lives of those people, help them understand what value might look like for them, and then help them co-create that. So the Creative Solutions Forum is the forum of last resort, and it's got commissioners on it, it's got managers on it, and it's got practitioners on it, and it deals with those cases where the person has had multiple handoffs, no one wants to work with them, or they are in the vernacular kind of hard to reach or difficult, or whatever other words you might have in Ireland for those kinds of people. But what they need is something bespoke, something customized to them and their unique circumstances. The other thing is they have to come to this forum, their risk has to be very, very high. Because there are plenty of other forums that can deal with less serious cases. It's got a standing membership of mental health, public health, adult social care, community connections. They are people who commission kind of housing, substance misuse services, and hostel providers. The strategic home for that is in our city is the Adult Safeguarding Board. They're a board that have statutory responsibility for vulnerable adults. Any other relevant service can attend that forum by invitation. So if we are talking about someone who's committing lots of crime, either the police can refer that case, or we would invite the police to that case because it's relevant to them. The ethos of the forum is collegiate, supportive, and creative. It's about not doing business as usual. It's about how collectively we can make thresholds and boundaries fuzzy and permeable so they work for people. The only real hard and fast rule is a service can't bring a case in order to hand it off. They can't come and say, I'm evicting this person, I'm kicking them out of the service. That's not allowed. And this is what it does. You have a full case discussion and you develop a bespoke response for that person. You aim to reduce their risks, get rid of any gaming or handoffs that they're getting. We never focus on reducing unplanned care. So we never set out to stop people phoning an ambulance or going to the ED or going into bed and breakfast accommodation or wherever it might be. But the impact of the forum tends to be that those things reduce. Here's an extract from the terms of reference. I won't read it because you're going to get these slides anyway and you can read it at your leisure. So we were asked to evaluate this last year. We've almost finished it, but I'm going to share some stuff with you. So these are the terms of reference. So that over the 9 years, there have been 248 cases to the cut-off date, to the 31st of December of 2023. And we randomly selected 100 cases using a random number generator. We reviewed each case by, as you can read for yourself, why they were referred, what their nominal problem was, etc. We interviewed loads of the people that participate in the forum using a thing called appreciative inquiry, which is a really open way of asking people questions. It kind of sits halfway between a normal conversation and formal qualitative research. The original sample, there were 248 cases, 14 were excluded because they were after the cutoff date. And it had also been previously evaluated in 2018, so we excluded those cases. So we got 100 cases from the remaining 182. These are their ages and gender identification. This is where they live. You won't know this, but the poor part of Plymouth is the PL1 and PL4s, where you see the big numbers. The west end of the city is very, very, very poor. What's amongst the poorest in the UK. And this is who referred. So Live Well is the community NHS provider. Plymouth Community Homes is the big ex-council housing, you know, when they were all shipped out in the 90s into these housing associations. The Plymouth Alliance is the Alliance for Complex Needs, but as you can see, it's probation service, Plymouth City Council, the police, the Assertive Outreach Service, Shelter, the housing organisation. Here's a kind of top list of the reasons people were referred. Very often the reason the worker refers them isn't, after discussion, it isn't settled on as the kind of real reason. But the kind of things you'd expect, really, from your own work. High risk of death due to suicide, overdose, self-neglect, physical ill health, substance misuse problems, domestic abuse, violent perpetrators of violence, all kinds of things. And this is kind of how often, this is the frequency of presenting problems. So on the left hand, you've got self-neglect, risk of death, risk of exploitation, risk of abuse, risk of death, violence towards staff and others, non-engagement with services, issues with mental health, to help someone find accommodation or because they're at risk of eviction for various reasons. And a lot of them had diagnoses. Now, I don't know what it's like in Ireland, but some diagnoses in the UK over the last 10 or 20 years have effectively become diagnoses of exclusion. If you have these diagnoses, you're very unlikely to get a service. And in particular, this would be the personality disorders, the emotionally unstable personality disorder, paranoid personality disorder, borderline personality disorder. So I'm sure you can picture these people in your mind's eye, but also a lot of people have physical complications. And they're the kind of minor diagnosis there: early psychosis, learning difficulties, epilepsy, that kind of thing. Now, Jim asked me to talk particularly about avoidable deaths. So in our 100 cases, given these are the riskiest people in the city, we didn't find a single avoidable death. There's a specific definition used in England for deaths, which is called an avoidable death. It's got a kind of fixed criteria. So suicide, substance misuse deaths of all kinds, fire deaths, domestic homicide deaths, they're all avoidable deaths. And we thought, well, this is not what we expected. So to cut a long story short, we looked at every single case that had ever been, because we thought this can't be right. Maybe we've just been lucky and picked a group that didn't die. So in the 9 years it's been running, we found there were 16 deaths in 248 cases. But when I then went to the avoidable deaths coordinator in the city, I ran their names through her system, and we were able to see that the vast majority of those 16 deaths were not related to creative solutions. Some of them were old age, some of them were accidents, some of them were natural causes. So we thought, well, let's look at anyone who died within 24 months of a referral to this forum. And we found 6 deaths within 24 months of a referral that met the definition. And these are them. So three men, 3 women. This guy in blue, he went to the forum because he was terminally ill. He lived in a hostel and he wanted to die in the hostel. And it wasn't possible for him to die in the hostel. So we designed an end-of-life pathway with our local St. Luke's hospice and built an end-of-life suite in the hostel so he could die in the hostel, and subsequently other people can choose to die in the hostel if they consider that that's their home. Now, normally in any 1 year, so these are the deaths of the last 5 years, these are the avoidable deaths we get in the city of Plymouth every year. The interesting thing is in 2022, the avoidable deaths group, the group that reviews all of these deaths, adopted the same practices as the Creative Solutions Forum. And you can see deaths have started to tail off. So we were kind of, why does it work? We thought, this is really interesting. Why does it work? So we did a load of interviews, some of which I'm going to show you because they're much more interesting than me. But one of the key things that the forum does is it focuses on worker fear as well as perceived risks. So very often people have these risk matrices, the likelihood of a thing happening multiplied by the imagined impact of that thing happening. And the research says they're as good as useless, but that's what people use. But what the forum does is recognize that anyone that works in the field, particularly of substance misuse, is in constant fear that people on their caseload are going to die because they die so frequently. So it actually works really hard to reduce worker fear. And in reducing worker fear, it enables the worker to take bounded risks with the client. So a normal risk forum would put more and more controls and more surveillance on the person using the service. And that makes them more and more resistant. But it also makes the worker more and more fearful. You know, God, if they're putting all these, extra surveillance on it, they must be really risky. And people kind of really feel that in their heart that this is a risky thing. So it really focuses on reducing worker fear. It's a really kind place to go. It's a really safe space to go. And it kind of is a really nice balance of challenge with support. So we did loads of interviews, and I'm going to show you some. So these are the questions we ask. What can you tell us about the Creative Solutions Forum? There's a word cloud of the most frequent things people said, but here are some quotes. So it's incredibly person-centered. It's about the rights of the person. We leave our political organizational agendas at the doorstep, and everybody there is expected to come with the offer of something, whether that be psychological support of the people in the meeting, whether it's just putting an idea out there, whether it's offering a solutions-focused plan, whether it's offering a physical intervention. But the plan is that everybody around that table is there for that person and that person alone, and takes any restraints of their organisation away at the door to help that person move forward in a safe way. So it's a really kind of, as I say, creative space. And there's another social worker here. It's really nice. It's kind. It's really trauma informed, because I think I think we forget how traumatized or how traumatizing it can be to work in this sector as well. Like, there's all that vicarious trauma that you're holding. And we need to make sure that the space we create for workers is kind, so that they do feel that. What do you value about the Creative Solutions Forum? The camaraderie that's person-centered. I've been involved in the Creative Solutions Forum ever since I came to Plymouth in 2017. There is something special about that forum that has the respect of partners. It's value-based, it's very ethical and clear and person-centered, and it's just a place where you know that everybody in that room is going to do their best to move something forward. A really good chance for people to come together and discuss some of the more complex issues, or issues that don't have an immediately obvious solution to them. If we didn't have it, that would reveal its value even more, because sometimes you're just a little bit stuck as an agency. And if you do get some very difficult, difficult situations, so very complex issues, a lot of the people we deal with have got complex problems. So the most common reason for referral on the referral forms is risk. So we ask people about risk, but actually they talked about fear. I think it helps people feel less fearful about risk and be less risk averse, because there's a wide, range of skills and risk perception in the room. So you can all talk, and you can sort of take a lot from what your colleagues or wider colleagues, external agencies are saying, because the way one provider might perceive risk might not be the same way that adult social care perceive the risk. And so it's about having all those different ideas and engagements from that. I think it's improved my confidence around risk and what I understand risk to be, because you've got all those people in the room with that knowledge, and everyone's at different levels and different, and it's a really helpful place to be. I think it's always been an area where people have arrived with what would be quite a kind of anxious, fearful situation. People often leave without necessarily masses of changes in that, but actually the problem shared part. So this goes back to that kind of support from first line managers and the organisation, and not feeling that with a caseload of 50 people, you're sort of just about hanging on in, and frightened to log off and frightened to go home, even because you're worried about what might happen. So sharing risk is important, and I think I've really encouraged people, that I don't think I've ever had any negative feedback on that. That's a quote from the chair. Has going to the forum changed your practice? Massively so. What I've been able to take from the Creative Solutions Forum is to replicate that on a smaller scale. So what we've done is replicate that in a much smaller area based on individuals. So it's a person-centered approach for that specific situation. So a safeguarding referral, it's almost like a mini strategy meeting. You know what I mean? It's like, where do we go from here? We don't call it a strategy, because a lot of the time the safeguarding thresholds have not been met. But it's the same sort of thing. This is the situation. What are we going to do? What does this person need from us right now to move that forward? And I think the way that we work in the Complex Lives agenda has really been informed by the Creative Solutions Forum, and people are familiar with it. Essentially, this is a quote where the person that runs the Avoidable Deaths group, so they adopted the practices. We've taken a Creative Solutions, kind of the way that the chair conducts those meetings, into the Avoidable Death Review group. So it's a no blame. Was this considered? How can we support change? How can we get learning from those deaths? And we've really kind of, used that Creative Solutions Forum approach, because I think it sounds soppy to say, it's a really beautiful thing to go to. It's a lovely meeting. It feels like it's a really nice community to kind of go and present something to. And I think that's kind of what we wanted to do with the Avoidable Deaths group. And the last thing is, we didn't ask a question about this, but everybody talked about the role of the chair, who kind of embodies a human learning systems approach. I think, let's call him Dave. I think Dave, who obviously chairs the meeting, does a really good job of holding that space, and for it to feel like it's a really kind, welcoming environment for people to present their case, and kind of there's no stupid questions type thing. and I think is very good at supporting or challenging organisations to look at changing their thresholds so that it does meet the needs of the person. I think Dave is bloody brilliant, and you can quote that. I just think the way he speaks, it's even his tone of voice. Like if he read bedtime stories, I'd listen to them. Do you know what I mean? He's got such a nice, like, just quality to him, a kindness. The chair doesn't have that kind of hierarchy kind of thing. You know, you're presented to people who are a head of service or something. You know, that's probably quite daunting if you're a newly qualified social worker or key worker. And also because you're worried that somebody's going to say, well, why haven't you done this? But that isn't how the forum works, thankfully. You know, it's not a why haven't you done this? It's a have you considered this? And I think there's a really important thing around language and creative solutions. It is very different. And finally, this is my favourite quote. I love coming to this forum. It feels like I get to do all the things I thought I was going to do when I became a social worker, which tells you they don't get that. They don't feel like a social worker in any other part of their work. So that's the end of that.
Thanks, Gary. Does anybody have any questions for Gary on that? Thank you for that presentation. I'm really, I suppose myself, I'm kind of thinking about just the approach that we have here to our trauma-informed care, our learning circles, around that kind of co-production and people bringing. But I think the Creative Solution Forum sounds like it's something that would be fantastic for us to try and pilot in the Southeast, and just that way of working. Based on who's here, guys, do you have any questions for Gary that you'd like to ask him while we have him?
Somebody asked a question earlier about data. So we still collect data on our KPIs. The thing with KPIs that causes all the bad stuff is if they're performance managed. So we collect data and then we treat them as learning indicators. But what we also do is we do a thing called ripple effects mapping. And if you Google it, you can see there's an NHS site which kind of gives you a kind of potted kind of example about how to do ripple effects mapping to capture all these emergent things that happen whenever you do human learning systems.
So what do people think of the approach that Gary and his team had taken in Plymouth to looking at kind of drug-related deaths? What do we think? Anyone, any comments or queries?
I chatted with Gary in the breakout, and I think there was a certain certain bravery and willingness to push the boat out a bit. You know, it's not. I think the story that they told there was uninteresting, but the breakout, there was it was a series of steps, I think, that led to this. So these things don't happen easily. I'm not trying to be pessimistic, but it's tricky. It's difficult. You have to navigate a highly bureaucratic system, which is, you know, important in ways, but we need systems as well. But it's how to present this as, you know, another way of doing things, not just in your own local place, your own particular service, but to I suppose ripple, to use that word from what Gary was talking about, across other areas. And I know that in the recovery field, particularly, it's why organisations like European Drugs Agency, they don't get involved in it because it's difficult to measure. It's hard to capture the data. It's hard, you know. There's always some reason not to, you know. But I think we have to keep pushing that door. Thanks.
Jim, I have a question, but I don't want to. Oh, I'm on mute. No, I'm not on mute. Jim, I have a question. Is that okay to ask?
Yes, of course. Yeah, yeah.
So it was for Gary. So I've now transferred to the car because I'm like, I don't know how many places I've tried to phone into just not to miss this. It's really, really good. My question is, in the southeast, in the HSE, well, actually nationwide in Ireland, in the south of Ireland, we're not collecting any KPIs. We've been given no KPIs for Roma health, and I suppose that's indicative of the status of Roma health, because everything is kind of more important. All the work with refugees, protection applicants, Ukrainians, it's all kind of like more important. And I kind of was asking that question at national level, like, you know, should there be should there not be KPIs for Roma work so that the work is taken seriously, and maybe there might possibly be some funding increases. But I'm just wondering, I'd just love to ask Gary, maybe thinking outside the box, maybe that route of metrics is not the way we should go. So look, in the whole of Ireland, there's only one dedicated Roma post at a regional level, and that's mine. So the Roma work is only beginning in the rest of the country, but in the southeast it's very well developed. But so I'm just wondering, that's the question. If you were trying to capture the outcomes, or at least evidence your work, like the importance of the work, the Roma health work that we're doing across like the Republic of Ireland, would KPIs, or is there another way that's not metrics that we could showcase the work, tell the story? That's my question.
Yeah, so as I say, the issue with KPIs is when they're performance managed. When they're performance managed, they are always gained. There are really no exceptions. And I bet people in this room have been involved in gaming. I was phoned by about 6 months ago, someone from government, and said, we're worried about this KPI in a particular thing. And I said, oh, well, we're pretty sure it's just a data artifact. And he said, yeah, but we're really worried about it. I said, well, if you like, I can game it for you. And he said, yeah, game it.
Is that
so
like
that kind of that tells you that kind of tells you that people prefer good-looking data to healthy people. We're all kind of trapped in that system. So you could set your own metrics to help you understand your work, but you could also you could have focus groups, or you could do appreciative inquiry with the people you're serving and the people you work with, to try to understand what matters to them, and to contextualize them so you can understand better what value might look like for them. And one of the things that it's a kind of a pretty glib thing that I say, I often say to kind of people who come and inspect you, is why are there no KPIs that basically say, that basically measure that at the end of a session you say to the person in front of you, do you feel better? I don't know of any statutory metric that basically is based on whether the person feels better or worse. There are all these kind of proxies. You know, were you discharged, or did you do? But you never asked do you feel better? So to have the opportunity without KPIs for you to develop a set of things that are meaningful to you and meaningful to the people you serve is a great opportunity. And I think, I mean, I'll happily talk to you about that kind of offline if you want to email me.
Brilliant.
But I've just noticed, Gabriel, you just put something in the comments.
Brilliant. Gary, thanks so much. Like, everything we do is with rather than for Roma.
Yeah.
It is a partnership approach, and we don't use the word co-design, but yeah, look, thank you so much. I really, that's absolutely fantastic. Thank you. Thanks, Gary.
Pleasure. I didn't see
I
what
think
you
there's a real opportunity for Suzanne to, while you're not being looked for KPIs, to actually find out what's really meaningful, and maybe to be influenced what national KPIs could look like if they were centered on lived and living experience of people that you're working with in that community.
Like the National Intercultural Health Strategy, you know, the core principle of it is that it's person-centered care. People should be involved in saying what they need and what their preferences are, and all of that sort of stuff. So this would be, in effect, Roma setting their own measurement. Yeah, I think, and that would be like we've led, Jim, on anything that's. It usually comes from the southeast, because I'm 11 years in this role, so that would be hugely valuable to Roma work nationally.
Gary, can I ask you a question, if it's okay? We spoke previously, and talking about the committee and the work. Were there changes that were made to practice as a result of that?
Yeah.
So even like we were talking previously about note taking, and so could you maybe talk about some of the actual practices that maybe changed from day to day with some of the services as a result of working in that human learning systems approach?
Yeah. So there used to be what's called a staged approach to housing. So if you were homeless, regardless of why you were homeless and who you were, you went to the hostel, and then you went to supported accommodation, and then you went to, there was all these kind of steps before you got your own flat. And they scrapped that and said, no, we'll just do an individual assessment, and if you can go straight into your own flat, you go straight into your own flat. I'm a really kind of simple thing. There was it's a kind of technical stuff, but there was a whole range of stuff around optimal methadone dosing. So when we audited all these people who were coming up to the forum, they were all on suboptimal doses of methadone. And the excuse given by the service was, well, they were all on stage reductions. And then when we looked into that, they'd been on a stage reduction for 2 years. So they'd been on a suboptimal dose for 2 years using other drugs on top to top up. So they weren't implementing the evidence. And so we got much better at making sure that people had an optimal blocking dose of methadone, for example. Another thing was street drinkers were treated, well, they were treated like vermin, that they were bad for business, that they were terrible beggars. And we started a managed alcohol project in hostels, so a designated drinking area. We bought them alcohol, low strength alcohol, normal strength alcohol, so they weren't drinking white cider. And they were issued that throughout the day. So they were kept not intoxicated and not in withdrawal in this designated. We even did it in the Sally Army, which is a temperance movement. Based fortunately, so we did it in 2 hostels. We took their liver functions before, and we took their liver functions at the end of the pilot, and their livers have improved. They weren't begging. They weren't causing social nuisance. What I'm trying to do at the moment is there's a derelict pub. I'm trying to buy the derelict pub, and I want to turn it into a members-only club for street drinkers. So if you're automatically enrolled as a street drinker into this members-only club, and it'd be staffed by helping staff, and you'll be given either given or have low normal strength beer, so 3 or 4% beer throughout the day. So kind of creative ways of looking at it. Another thing was smoking. So a lot of people were drinking, were smoking. So we looked at a smoking cessation service. They hadn't had anyone from a poor postcode for about 5 years in their service. So it was increasing inequality between wealthy and wealthy non-smokers and poor smokers. And so we went to that service and said, which group of people would you never want to come to your service because they'll never be a successful target? And they said rough sleepers and people living in hostels. And so we gave 20 of them a free vape and a 3-month supply of a liquid of their choice, vape liquid of their choice. We had 100% take up at the end of the pilot. 60% of them weren't smoking at all, and all of them had reduced their smoking. 2 years later, that was still the case. It was a quarter of the price of a traditional smoking cessation offer. I went to interview one of the participants, and when I arrived at the hostel, he was trying to persuade a hostel worker to stop smoking and start vaping. But as a consequence of that, because we'd shown an interest and been person-centered with them, loads of them started to engage with other services. It was no part of the experiment. Some of them got their teeth fixed. Some of them started engaging with mental health services. It was almost like, because we'd shown a bit of interest, they started showing an interest in themselves. It was a really odd, but frequently happens when we do this kind of thing. So now we have these schemes in Plymouth that the GPs in our poorest areas, they all have a supply of vapes, and they can give them to poor smokers who've got chest disease. Similarly, the maternity ward has got free vapes. The chest ward has got free vapes. The hepatology ward has got free vapes. every smoker who's allocated social housing gets a little box called New Home, New You, and in that box is a free vape and 12-week supply of liquid, amongst other things that they get when they move in. And it's dramatically reduced. Listen, it's not perfect. It'd be great if they weren't smoking at all, but we don't want to let perfect be the enemy of good, and it significantly reduces their risk. So we have lots of those little kind of projects. Human learning systems, you can do it, as I say, you can do it at the level of the individual. So last week I was talking to a midwife about how she can adopt some human learning systems practices in just in her patient group. So she sees 60 women a year, and I was explaining to her how she could use some of the techniques of human learning systems to improve her personal practice. And then the following day I was talking to the UK Cabinet Office about how they might do these things at a national level. So you can do it at every level. It's a different way of doing business, really. It's much more collaborative, collegiate. It's much kinder. People often say it's a bit harder because you can't just give everyone the same 6 things you gave everybody else, but it's much more rewarding. So one of the byproducts of this is staff sickness tends to go down. So I did a project with where there were a group of staff, kind of minimum wage staff in the council, and their managers weren't getting on. They hated each other. 22 staff on long-term sick, and we taught them appreciative inquiry, got them to interview each other, mapped out where staff lacked mastery, autonomy and purpose, how you give it to them. And they went from the worst staff survey to the best staff survey. They went from 22 on long-term sick to 4 on long-term sick. They won an award. So kind of good things happen if everybody wants to be treated like a human being, right? And I don't know what, I had a health thing last year, and it's very frustrating when you're not treated like a human being. You're just treated like, we've got to get you in, get you out, get the next one in. And that's because what the research says is that stressed staff are less empathetic, and we want to encourage empathy. And what appreciative inquiry does is it reminds, when people do it, it reminds everybody how much we have in common with each other and how small the things that divide us are, rather than, a lot of the modern world these days is about focusing on these tiny things that divide us. So it's once you get going, everybody really likes this, and there are kind of tangible benefits. And just things like substance misuse agencies notoriously have very high did not attend rates to appointments. We were able to reduce what a service in-house, if they had a DNA rate over 60%, we were able to reduce it to 15%, just by helping them understand. So the common misconception in substance misuse is that staff are instrumental in people's recovery, and they are, but not in the way they think. So since 2010, I've asked about 900 people, why did you get better? I asked them 2 questions. Why did you get better? And tell me about a helper who was really important to you. And when I asked them, why did you get better? They all say, I don't know. And I said, but someone did eye movement desensitization and reprogramming. And they say, yeah, it was helpful. I said, why didn't you get better then? I don't know. And then they say, I didn't want to go to prison anymore. I was fed up injecting. I've got a girlfriend, I've got a boyfriend, I've got a flat, I've got a job. I just kind of grew up a bit. And that's what the research says. What the research says is there's a natural history to substance misuse. The Gene Hayman's research, the quantitative and qualitative features of quitting drugs, that people give up a fixed percentage, 5 to 7% a year. You can't make it go up, you can't make it go down, and you can't predict which 5 to 7% of people it will be. So the really important role of services is to keep people alive and healthy so they can mature out, and to provide them little small steps on their journey to recovery. But staff often want to feel that they're really instrumental, that they're going to cure this person, and they don't. but they are really important, but it's just not in the way they think.
I'm really interested in the and this is my own personal bias. I'm really interested in that members club for people who are drinking in the open. So how is that? Who? And this is probably a terrible question. Who buys the beer?
Well, so it's at the time I tried this before COVID. I was in the process of acquiring the pub, and then COVID happened, and so I did it in the hostels. But it's really cheap to buy. You know, you can buy hundreds of cans of kind of bog standard lager for much cheaper than a couple of deaths. If you cost the deaths, or sorry, my dog wants to go out. If you cost deaths or ambulances or hepatology stays, it's cheaper to buy them 3.5% alcohol, or the police time constantly moving them on. You know, the police in our city were putting spikes on benches, and it was so that street drinkers couldn't sit on them, and we had to point out, well, neither can anybody else if you put spikes on them. What are you thinking? And the police were actually very supportive. One of the other things the police did, we had this conversation with them, say, you keep arresting these, we get them in the hostel, they come out of prison, we get them into the hostel, just start to get them stable, you arrest them for something really trivial, they get 2 weeks in prison, they come out after 7 days, and we've got to start all over again. So you know, we want you to do an experiment with us where you employ 2 officers whose role is not to arrest people, whose role is to kind of be creative, to find alternative ways of managing these nuisances that works with the grain of what services are trying to do, not against it. And they've been amazingly successful. You know, they've got all the kit. They look like coppers, but they're like assertive social workers.
Yeah, we had something similar here prior to, I suppose, the downturn in 2008. We had community police, and the community policing really had a massive impact in kind of, we had it in a rural area here, an urban area in South Tipperary in Clonmel, where the community police were particularly effective at interacting with people that maybe had been arrested for possession or use, but actually interacting with them after, saying like, hey, have you gone and talked to the outreach worker, have a chat? And I spoke to one guy, Gary, and he said to me, Jim, he said, when a cop tells you that you need to do something about your drug use, he said, it's probably time to start looking at what you're using if the cops are telling you go for treatment. But they were able to kind of get guys driving license, support them with different fines and stuff that they had. It had a massive impact on the guys themselves in terms of their relationship, but also just feeling that they were being supported. And unfortunately, that's cut. The community police has been cut.
So we have this scheme called targeted police referral. So we used to have arrest referral. So police arrest Gabriel because he's a nefarious character, and then they refer him to a drug service. And we have drug treatment and testing orders, you know, I think whatever they're called now, drug rehabilitation requirements, where you go to court and you get sentenced to treatment. And I said to the head of the cops in Plymouth, you know all your prolific offenders. And he was like, yeah, we know them. We know their family names. It's the kind of generations of, and I said, why don't you get your officers to go out, knock on the door and say, Gabriel, we know you're bang at it. It's just a matter of time before we catch you. Why don't you come and get some treatment instead? And literally we had policemen driving criminals like Gabriel. Sorry to pick on you, Gabriel, to the treatment service, and they start treatment on the same day. The police still pursue the crimes, but when they go to court, they'll say, listen, this person's stable in treatment, they're not offending anymore. Give them a treatment order, and they get a treatment order. So it's kind of what we're doing then is kind of reduce. Well, they stop I think the results were it reduces their offending by 66%, and they start treatment, and it saves wasting police time. It saves wasting everybody's time. The issue is that they're a drug addict. They have to commit crime because they can't. No one can afford that kind of money. Not even you'd have to be pretty wealthy to support a crack and heroin habit.
Yeah.
So all these things are kind of cheaper. They're more sensible, and they're more interesting.
Yeah, thanks for that, Gary. Does anyone else have questions or comments from today for Gary or Gabriel?
I have one question, Gary, which is like you mentioned this bit about the Plymouth Alliance and just pooling the funding. How important is it that the money moves in different ways? Because, in the traditional setup, the money saved for the police or for hospital A&E isn't going to affect my budget over here, and therefore I'm less willing to, spend money here so that it's saved elsewhere in the system. So what were some of the things you did to just kind of...
So we legally pooled all of the council's budget with the local NHS budget. So we made a single legal heap of all the money. It's just under £1 billion. There are some bits of money we're not legally allowed to pool. They're to do with protecting children. But it's all legally pooled, and we have an integrated commissioning team of health and social care commissioners. So if I save money in the ED, which we frequently do, I can spend it in hostel, and vice versa, and that happens. And certainly in England, there's more and more of that kind of thing happening, place-based budget pooling. The other thing is we have aligned strategies. So we have the Plymouth plan. If you Google that, you'll see it's just 4 strategies that everybody signs up to. So everyone's kind of working together. And over the last 25 years, the culture has become just much more collaborative. It's kind of a default thing, where in lots of other cities, it's novel if you get everyone together. But we do it so often for so many issues now. It's just become part of the culture in Plymouth is to be collective about it. So we're a long way from London, which is an absolute boon. We're nearly 300 miles. I mean, I live 300 miles from London, and because I live in Cornwall. But and we realised about 20 years ago, there's no cavalry coming to help us. That no one's going to come and help us. We're a long way from London, so we've got to do things for ourselves. We've got to get together and kind of work things out. Being so far from London also means we get much less interference. So we were able to do a lot of this under the radar. And then by the time London got interested, it was all good. So they were just trying to learn from us. And we've just been offered, I probably shouldn't talk about it, but we've just had a very interesting offer from the UK government to do with place-based stuff. Us and some other places.
It's often the case, Gary, isn't it? That somebody has to kind of take a risk somewhere, to do something differently or to take on different ways of working. It's almost like the system needs somebody to put their self out there to make sure it's okay, and then when nothing bad happens, it's you get that kind of adaptation. But the system itself is nearly overly designed to mitigate that risk. Yet innovation happens when somebody actually says, something, we need to take a risk here. We need to do something different. We need to...
I think that's what happened to us, Jim. So after the 2008 credit crunch, everybody realized that what we did in the past was no longer affordable. We couldn't be the way we were. We didn't have them. My council is half the size and has half the money it did 15 years ago. So you can't. So the council has to have some organizational humility. It can't swagger about like it owns the place. It doesn't have the staff or the money. So it as a council and as a local NHS, it was more about having some humility, inviting other players to do the vision thing with you, and then they'll start spending their money in your place because they feel they're part of a shared endeavor. And it's just this kind of, you just keep put one foot in front of the other, try stuff, learn, embed what works, try something else, and eventually you'll get there.
I love that term you used. We were just organizational humility. I really, really like that term, and I think that's something that's, we're looking at, we're embedding the trauma-informed care practice in the Southeast, and doing that from a co-production learning system approach, really, and I love that idea about organizational humility, and what does that look like? How good are we to bring people in, or is it, as you said earlier in the presentation, it's not about pawning people off, it's about working with, and sometimes even that notion of case management can sometimes, look like it's not a pawning off, but invariably ends up in some cases as a pawning off. So I love that term. I love the way you put that term. It's organizational humility, and what does that look like? I think that's something I could definitely, I know there's some members of our trauma-informed care collective here. I think that's a lovely thing to explore within this. What does organizational humility look like when we're working with each other? Yeah, that's it. Thank you for that, Carrie. Is there any more questions or comments for either Gary or Gabriel? Anything that's kind of, maybe if we had a share from people, if you're comfortable, what's the moment that's sticking out for you, or is there a kind of a nugget that's sticking out for you from our presentations today? Would it be okay if we ask that question? Not to put people on the spot, but just to kind of see where are we at in our own thoughts and integrating it maybe into our own worlds.
Put it in the chat there, but just Gary, when you said, I think you were talking about kind of, the risk aversion and the kind of vibe or the culture it brings to places, but when it's the opposite, you said you can just feel it in your heart. And I thought that was lovely, and kind of, I think for us, or for Better Together, it can feel that way. But it just puts it really simply. But it's this massive kind of intangible thing at times, I suppose. But it is that you can just feel it. And it's just that sense, and without going into all the words around safety and positive risk taking and everything. So yeah, when you just said you can feel it in your heart, I thought, that was really nice. So thank you for that.
Thank you. Jim was talking about, some other people have been talking about language, and there's been an interesting shift in language. So one of the things we started to say in 2012 was, we will not use the language of conflict to describe the delivery of care. So we don't talk about frontline staff. This is not a war.
Yeah.
These are staff who want to do good in the world, being faced by people trying to access services to which they are entitled. The scarcity in resource isn't the fault of either of those parties, so we shouldn't use the language of conflict to describe the delivery of care. Our contracts used to be full of the language of business and transaction, and as well as the language of conflict. And there was none of our language. Our language is service, duty, care, love, compassion, support. They weren't in our contracts, and now they are. And it makes a tangible difference. I mean, language is thought, and thought is language. So it's a really kind of subtle thing. And the way we did it was not by, people said the wrong thing. We're like, you said the wrong thing. We just would say, we invite you to join us in not using the language of conflict to describe the delivery of care. And if I was in a meeting and someone said frontline staff, no one would pick them up, but everybody else would say public facing staff. Yeah. And then people tune into that. You don't need to wag your finger at anybody. This is a collegiate thing. And in the Creative Solutions Forum, people will talk very movingly about how they feel about things. And that's important, because that's what it is to be a human. And for a long time, people felt it was a shameful thing to care, that you had to have boundaries, and you had to be, Of course, you need boundaries, but you know, often it became a way of othering people, and now people use much more inclusive language, much kinder language, and with each other, they're much kinder to each other. Where, you know, that quote about, so when I was doing the research and we were looking at the referrals, my colleague, he's an academic who's never worked in this field, and she after doing it for about 4 hours, she rang me and said, I'm finding this really traumatic, just reading these cases. And it made me realize how much trauma, you know, everyone talks about being trauma informed, how much trauma workers are exposed to on a daily basis. So much so that you don't even notice it. And it takes a stranger to come in and say, that is not normal. That is really traumatizing. So the trauma stuff, it needs to apply to your colleagues and to yourself. And human learning systems is unashamed about that we're all human beings. You know, you can't just switch these things off. They're traumatic.
Yeah. Thanks, Gary. And just picking up on what you said about language, I think Suzanne said earlier about the hard to reach. And yeah, just appreciated you saying that, because it just feels like kind of arrogant or something, doesn't it? Like who's deciding, you know, and if someone's not offering me something that I need or want, then I'm not going to be easy, you know. So it just, but yeah, it was nice to hear that, because I've not heard it in many spaces. But yeah, I think it's really important around the language. So thanks.
And just really briefly, because I know I've spoken a good bit, so I don't want to take up too much time, but just to thank Gary and Gabriel, like everything you've said is, I've learned so much, but like I know the stuff that you're saying works. Jim, I'm just thinking of a group, like when we went into Tipperary in the middle of COVID trying to find Roma and give them health information, we partnered with a youth service, and they just had the CEO of the youth service, he led the project and worked on it with us. It was 2 different HSE areas with the youth service. But exactly what you said about collegial and collective, he just managed to set this really informal, welcoming, inclusive, kind, caring tone for an interagency steering group with people from the council. We had TUSLA, housing was an issue. It was all of the issues. And that group is 4 years on and nobody wants to leave it. Even agency staff who've changed roles, they're trying to find a way to stay involved. The commitment to it has been phenomenal, because like a really good worker, really good interagency structure, and because we set, like, people when they first joined, they were like, we know nothing about Roma, we don't know anything, and we said, okay, we'll put shared learning as an agenda item. It was the first item on every agenda, none of this minutes and matters, and we had a Roma rep on the steering group, so everyone learned together, and we learned as we developed, and we drew on other people's experience of working with Roma. So everything you said is actually put into a framework of why that project in Tipperary has worked really, really well. All about relationships, all about trust, care, compassion, and collective working. And everybody brought something to the table, not even money, but they just brought a willingness to work.
Yeah, I mean, I have to go in a sec, but a really simple thing that everyone that has experienced, if you work in these kind of things, if there are 2 workers and they are both trying to get a service from a third party, and you know the other worker in the third party, and the other worker doesn't, who's going to get their client seen?
Yeah.
It's the person who has the relationship.
Yeah.
So when you make relationships across a system, it becomes much harder for one service to stiff another service.
Yeah.
You're much less likely to do that if you know them and you know they're a good actor and they want the same things as you.
And I not for now, but it would be lovely to hear how you can do that past the individual relationship. You know, like we might have one key contact in the local authority for housing, but if that person leaves, where are we then? So it's like, but that's for another day. I know you have to go, but yeah.
Well, it was lovely to meet you all.